time zones. It's really exciting to hear about the weather in all the different countries. And I'm really, really happy to speak to you. I've been following the fantastic discussions online, very good thinking and interesting discussions and excellent questions. So today we're going to be talking about surge capacity, and I also added a little bit on another relatively new concept called crisis standard of care. And I'll give you some of my perspectives and experiences, and at the end we'll be happy to entertain any questions. First of all, what is surge capacity? It's relatively new terminology in the field of medicine, and it's sort of difficult to describe. There are a lot of different models, but there's no real standardized definition. So it's really more of a concept. And what I'm going to share with you today is one simple approach that we developed in conjunction with my colleague, Major General Donna Barbish, called the 3S concept of surge capacity. And we'll learn what those three components are, and that's the main takeaway message of this entire lecture. It's kind of a strange word, surge capacity, to the field of medicine. Usually you think of it when you're talking about electricity or something like that. And one of the things we're looking at is how do we talk about it in different cultures and different languages. And my belief is that we should continue to use the English word surge capacity even when we're speaking in another language, because when you start translating it, it gets even more confusing. And my colleague and I did a publication in the German language, and the publisher agreed to let us use the English word surge capacity, even though the rest of the paper was in German. Another thing I wanted to mention to you is that even the lay public is aware to some extent of the concept of surge capacity. And unfortunately, I had to call the paramedics this weekend for my 95-year-old mother. She's doing better now, but she had to sit in the emergency department for about 15 hours, and I was talking to her, and she said to me, "Why don't they have any surge capacity in this hospital to find a bed for me?" So even she had an idea of what it is. One of my first experiences where I started thinking about these issues was in 1989 when I was a chief resident at the trauma center in Oakland, California during the Loma Prieta earthquake. And what happened was I was home and my roommate said to me that there's an earthquake. And I've been in many earthquakes around the world, and I told her, no, there's no earthquake. It's just the washing machine on the spin cycle. The house always shakes like that when the washing machine's on the spin cycle. And she said, well, we're not doing any laundry. So I decided, yes, that was an earthquake, and I decided I needed to the hospital. Communications were not really functional. And when I got there, I worked as the triage officer, and I thought about what do we need to do in this situation. It looked a lot worse than it was. They kept showing pictures of the Cypress structure you see there on the left bottom collapsing, and the Bay Bridge you see there on the right falling apart. But the rest of the community was actually relatively intact. The problem was we had no communications with paramedics for the first 6 hours, and so we didn't know how many patients we would be getting. So I started looking at things like I told one group of people to go up to sleep in the call rooms, and we would wake them in 12 hours so we'd have more staff later. And we actually had a patient come in with an open fracture that normally would have been sent to the operating room, to the theater, to have a washout. But instead, I took care of that patient by cleaning the wound in the emergency department and sending them to the intensive care unit to try to preserve the operating room for more critical patients, which in the end it turned out we only had about 6 critical patients the entire evening and didn't need. But these are some of the kinds of issues, at that time I had no real training, I was just a resident, that we have to think about in these kind of situations where things are evolving and you don't really know how bad it's going to be. Some other background considerations are just healthcare in general. We have gotten a lot more cost effective. we've made a lot more attention to saving money. And so with managed care and other types of strategies, efficiency is better, but we have things like just-in-time systems where we no longer have extra antibiotics or supplies or other types of things sitting around. We just have what we need to save money. And that works fairly well under daily circumstances, but as you know, when there's a disaster and we need surge, we need more supplies, it can be a problem if we haven't planned. And just on a daily basis, there's a lot of crowding in our emergency systems. So when we have some type of catastrophic event, we need to have some type of surge system to be able to care for patients in that setting. And what I mean by a catastrophic event is something large where the needs of the patients exceed the resources at a given point in time. And we're in what we sometimes term an allocation of scarce resource scenario. And you can think, I'm sure, in your countries of many different examples of how this has happened or how this could happen if you do a hazard vulnerability analysis. I do want to emphasize the point in time, because if you have an event that's changing over time, you may either get more resources from an outside source, for example, or you may get more or patients. So things are changing, and it's different depending on what timeline you are during the event itself. So surge capacity, you need it when patient care needs exceed resources at a given point in time. And in some countries, for example, the United States, it's very rare that this would happen. In other countries, it may be more common. It doesn't have to do with the absolute number of patients. It has to do with this mismatch of needs and resources. For example, even a smaller scale event, to give you an example, if you had a car crash and you had 5 critical patients and you were in a major city with trauma centers, it would pretty much be business as usual to take care of those patients. If you had those same 5 critical patients in a rural area where you didn't even have a hospital, or you had a small hospital without a doctor even in the hospital, you would need to activate your disaster plan and create surge capacity to care for those patients. So it's not really the event itself, but it has to do with what resources you have at the time of the event compared to what the needs are of those patients. And large catastrophic events, they can be many, many different types of things. I'm sure, again, you can think of examples in your countries or perhaps disasters where you have deployed. Typhoon would be one example. A catastrophic earthquake. A tsunami. You can also have a planned mass gathering. And for example, if there were a terrorist attack, we were watching the Sochi Olympics. The newspapers were calling me saying, will you be on call in case there's a terrorist attack? There can be explosions, biological event, chemical attacks. So this is something we might be involved in the planning for if something were to happen when we had large number of people at the same place in the same time. Or you might prefer Oktoberfest for your mass gathering. Planned mass gatherings and types of them. Another scenario would be a dirty bomb, and in this case, the amount of radiation is not that much of a problem. It's more the explosion and the casualties from the blast injury. But one of the very big things we would expect in the dirty bomb scenario is what we call psychological casualties. So people who are concerned because they're afraid and the radiation is unknown, and there could be hundreds or thousands of patients seeking care who are concerned that they have been exposed but haven't really been exposed where they'll have a problem, but we still have to manage that large influx of patients in the healthcare system at the same time that we're managing our daily emergencies where things are already crowded and busy in the emergency department or in the EMS system or whichever system you're working in. Another example would be pandemic influenza, very different type of event. It's coming over time. There may be a first wave and then later in the year a second wave. And these are the types of things we have to plan for. And the surge capacity is different because The principles are the same, the concepts are the same, but the types of things like antivirals might need to be stockpiled, for example, where you wouldn't need that in a bomb or blast scenario. So here is the bottom line that I want you to take away from today, is to learn the concept of what we call the 3S surge system, and we'll go through this. It stands for staff, stuff, and structure, 3 S's. The goals of surge capacity are to augment the patient treatment capacity and improve population health outcomes. So we're not still looking at individuals so much, but we're more looking at entire populations. And the components, again, staff, stuff, and structure. Now, in reality, there are 4 pieces to this surge system, but since it's easier to remember things in 3s, we put 2 of these things under structure, and I'll explain what I mean by them, but it's a physical infrastructure like a hospital or an alternate care site, and the second component of the structure S is the incident command system or the management infrastructure. The first component of the 3 for surge system is pretty obvious. It's the stuff, so supplies and equipment that you might need. Traditionally, there has been a lot of focus on this piece, on the stuff. And I do some consulting for the state of California in addition to working at the university. And one of the things that happened when we were planning for a pandemic is the governor's office called me and said, Dr. Koenig, how many additional ventilators should we purchase for the state of California to be ready for a flu pandemic? And I said, I think that's the wrong question. The ventilators don't operate themselves, they don't deploy themselves. We need a whole system for this. And they said, we know, but the governor wants a number. So you will commonly see that politicians want a number because, and the media also, if you do interviews, they want a number. It's tangible, it's easy to count, it's easy to see. And what happened is we did some modeling and we came back to them and we said we think we need 6,000 additional ventilators. And every single time I went to a meeting after that, people were rattling off, well, we're much more prepared right now because we have this and we have that and we have this and we have 6,000 additional ventilators. And I knew to some extent that number was pulled out of the air, but it makes them feel more comfortable to be able to have this number and to feel more prepared. So there's purchasing of pharmaceuticals and supplies like ventilators, antiviral medications. Some of the large grants in the U.S. that came from the federal government were used for hospitals to purchase decontamination and personal protective equipment. And it is important to have all this stuff. But if you don't have training how to use the personal protective equipment, training how to do the decontamination, a system to access it 24 hours a day and so forth, it will be worthless in and of itself. So it's a key component, but it's insufficient in and of itself. And buying the stuff is not enough. This is a picture of not how to prevent spread of the bird flu. Some of the other scarce resources you might have to look at creating surge capacity for would include, in addition to equipment and medications, you have to look at all different types of settings. So not just hospitals, but outpatient settings like clinics, urgent care centers, physicians' offices, alternate care sites like schools, any place where you might set up care that's outside a hospital. Because remember, the hospital could be non-functional, for example, after an earthquake or a typhoon, and might need to be evacuated. And another big area is more and more we're doing stuff at home. There's home health care. Patients are on oxygen. Patients have medical devices that need electricity, that need backup. So when we're planning, we have to plan for the entire community and not just pieces of it. The second component is staff, and that's us, that's personnel. Some of the things we need to consider, in addition to absolute numbers of people to help, is what I call behavioral issues. So will people come to work? If there is, for example, a smallpox outbreak and you have a small child at home, will you be willing to come to work, or will you be afraid you'll catch something and bring it home to your family member? And there's the opposite side of that too. There is also what we call convergent volunteerism, where people show up unannounced and perhaps aren't trained or aren't credentialed and can become part of the problem because you have to manage those people, ensure they're appropriately trained and protected and credentialed before you allow them to work, and that takes away from your management of the actual event itself. The other thing is it's not just the staff, but do they have the right skill set? Back to the Loma Prieta earthquake, I had a physician come up and say, I'm a visiting dermatologist, I want to help. And I had to say, well, thank you, but we don't really have any dermatologic emergencies during the earthquake. So you might need infectious disease specialists, you might need trauma surgeons, you might need neurosurgeons. You have to look at the type of event to see specifically what kinds of skills would be needed for the surge capacity staff component. And then the third S is structure, and again, it's really two separate things. The first part of structure is the physical location. Where will you take care of patients? Is it a hospital? Is it some type of alternate care site? One of the things I always say is beds don't take care of patients. We have all these elaborate procedures. When I was in charge of the Emergency Management Office for the Federal Department of Veterans Affairs from 1999 to 2004, we had a requirement to go across the country and count beds in our National Disaster Medical System hospitals. And it just doesn't make sense to count beds, because you really have to look at whether you have staffing, whether you have other types of things, plus you'll find other ways to take care of patients in alternate care sites or create more capacity with gurneys, etc. So it's not just the beds. And it probably used to be a good surrogate marker of patient care capacity 20 or 30 years ago, but right now hospitals are so crowded, there's virtually never any quote-unquote beds available. So just keep that in mind. You'll hear the terminology a lot that we're counting beds, but it's a lot more than just the bed. And the second part of structure, which is really, really important, is the incident management system, the infrastructure that coordinates everything. That is absolutely key component of surge capacity and management of any type of disaster. It could look something like this. There's all types of different models and locations where they could be. You have to see what works in your particular system, and you have to think about it ahead of time. Here's another example of what an alternate care site could look like. And I'm looking if there's a question here. This is a picture from the 1918 influenza pandemic, to a nice historical shot to give you an idea of what an alternate care site could look like. And in this case, in the U.S., there was 550,000, so more than 500,000 deaths in less than 10 months, and 4,000 deaths per day in the month of October. So when we're talking about pandemic planning, these are the types of things we can realistically plan for. And in fact, in World War II, more soldiers from the U.S. died from influenza than died in battle. So that gives you a sense of the magnitude and why we're so concerned in watching these emerging infectious diseases and looking at how we would have surge capacity in this type of event. In modern times, do we really have a lack of resources? This is, again, a U.S. example, and it's going to be different in every country, but there was a study done by a Professor Quarantelli out of the University of Colorado. He's a sociologist, and he looked at 29 disasters in the United States where there were more than 1,000 casualties. This is historical. And in that case, he only found supply shortages, so stuff shortages, in 6% of cases, and personnel, so the staff piece, shortages in 2% of cases. So what was the problem with managing these disasters? It was a lack of a management system to organize the available resources. So there are many times when we actually have sufficient staff and stuff, but if we don't have that third S, the management structure, the incident command system, then we're not able to effectively manage the disaster. And Hurricane Katrina in the U.S. is not one of our proudest moments. I say, was that an exception? Because people did die there. But I would say if you look at all the vast medical and health resources across the entire United States, perhaps it was more that we weren't able to get the right resources to the right place at the right time than actually exceeding resources. It's not entirely clear. And here's an example of an alternate care site during Hurricane Katrina and what that looked like. So back to our 3S, again, this is the one bottom line take-home message I want you to go away with today. Is the 3S surge system consists of stuff, staff, and structure. Let's look at a pandemic example. If you look at preparing for a pandemic, like that picture I just showed you from the 1918 flu pandemic, the kind of stuff you would look at stockpiling and creating surge capacity for include, of course, ventilators, antiviral medications, vaccines, personal protective equipment, and even ECMO, extracorporeal membrane oxygenation, like you see on this baby here. Not all hospitals are ECMO capable, and during the 2009 H1N1 pandemic, we were actually looking at this issue because this is one of the things you can do for critically ill patients to help save their lives, and looking at transfer agreements and where would we have ECMO services and that type of thing. And another thing, actually, believe it or not, we stockpile now for a virus, for a flu pandemic, is antibiotics. And why would that be? Well, that is because in H1N1 you can get a secondary bacterial infection like a staph pneumonia, and then you would need antibiotics. So you really have to look at what are all the potential needs for each type of disaster. Then planning for staff in an infectious disease pandemic like H1N1, we look for certain types of specialists, like infectious disease specialists would be one. And then in terms of structure, in addition to the usual physical locations, we might look at when are we going to use intensive care versus a regular ward versus maybe having someone quarantine or isolate at home, depending on what's going on with them and how we might get them care in the home. So the whole spectrum and the whole continuum. And of course, as always, the incident command system, which in the past was used more for pre-hospital settings and more for trauma types of settings. So it's only relatively recently that we've started applying those same incident command system principles to things like a pandemic. For example, in the United States, the Centers for Disease Control and Prevention really wasn't doing this until after the anthrax attacks in the fall of 2001. What they would do is a more delayed epidemiologic investigation, and they weren't that used to doing an emergency type of response, and that was put in place, and they had new emergency operations centers and new procedures and trainings that are all working today, but prior to 9/11 really were not in place for a pandemic type of event or a bioterrorism type of event in that case. Now I want to talk just a little bit about standard of care within a surge system. So this is that other topic I mentioned, the crisis standard of care, to give you a little bit of background and perspective on that. First, I want to give you a scenario. I'm not going to discuss the answer to the scenario. This is just something to think about as we go through the next few slides. Here we have a patient with cardiac arrest. And the question is, do you resuscitate? Do you do CPR? What would be the standard of care? So just keep that in the back of your mind as we talk through this issue. Standard of care, and there is some debate about this, but in my opinion, and many people would agree with this, it's a legal definition. What would the prudent person, in this case a healthcare worker, do under similar circumstances with similar resources. The goal in the SURGE system is, as I mentioned earlier, we're moving more from focusing on individual patients, like that individual patient in cardiac arrest, to population care, to doing the most we can for a population. And so whether to do cardiopulmonary resuscitation is going to depend on everything that's going on. And what we need is we need to know, when are we moving from a focus on the individual to a focus on the population? That can be a difficult question, especially if you think back to the Loma Prieta earthquake example, and I didn't send that patient to the operating room. I didn't know. There's a lot of unknowns. I thought maybe I could get hundreds of patients all of a sudden. So there had to be some trigger to shift to what the term we've coined is crisis standard of care. And it's difficult sometimes because you don't know. In the U.S., there's something called the Institute of Medicine, which is a very prestigious body, and they looked at this issue after we discussed it and coined the term crisis standard of care in California. And they actually came out with a report that you can easily find online called Crisis Standards of Care. In my opinion, they kind of missed the boat because there's only one standard of care, not multiple standards by definition. But this is how they decided to talk about it. And there has been a lot of discussion over the years. This is, again, a U.S. example where they've called it an altered standard, or they've even said graceful degradation of care, or diminished or lower standard of care. And I think that we all kind of mean the same thing, that we're trying to do the best we can under the circumstances, but I have cautioned in my writings against using this terminology because I think it would be really misinterpreted by the public and the news media to say that, you know, you're getting graceful degradation of care or an altered type of standard. What we ultimately did in the state of California, since there was a lot of discussion and debate with the lawyers and others on this whole standard of care, is we just started calling it crisis care, because people have in their mind, what is a crisis? And so this gives the idea that we're in this situation where resources are exceeded or potentially exceeded, and we're coming up with ways to maximize population health outcomes. And one of the things we look at is we want to provide equal and ethical delivery of health care in a disaster across the region. And we'll talk in the residential session a lot more about ethics, so this is just sort of a brief introduction. But in terms of the principles, it should be equal and ethical. In other words, if you need a ventilator medically, and you go to one hospital, and another person has the same condition and goes to a hospital down the street, you should both have the same chance of getting a ventilator. It shouldn't be dependent on whether you just happen to go to one facility or another. We have to look across the entire region. That's the principle. Putting it into practice, quite a bit more different. Looking at a catastrophic disaster, we don't alter the standard of care. What we do more is change the goal to optimize population rather than individual outcomes. We need these triggers to shift to population management, and then if it's a prolonged event like a pandemic, where maybe there's a time when you do have enough resources, you have to shift back to standard operating procedures, back to the individual management. So if you have this prolonged event, you could be moving back and forth multiple times during a single event, and again, everyone needs to be on the same page and doing the same thing. At the bedside, some of the issues, this was another project we did with the University of California at Davis, where we looked at planning and we did surveys and breakout groups. Of course, doctors don't want to be told how to practice medicine. They want autonomy, but that's difficult when you want to have the same thing in the entire region. There was a desire for definitions and triggers for implementing crisis standard of care. And what we ended up doing is defining broad categories that were more functional and not specific, like pain management, antimicrobials, but not specifically which techniques to use. and also looking at specialized hospital care resources like the ECMO that I mentioned before. Other factors that we looked at is that the implementation and the termination of the protocol should be an administrative decision. In other words, you shouldn't have a doctor at the bedside looking at a baby who needs to be put on a ventilator and it's really a futile situation and we don't have enough ventilators. That doctor shouldn't have to just say, no, we can't put this baby on the ventilator. We should have somebody sitting back looking at the big picture and looking at things across the whole region and making protocols to help us decide what to do to make things equal and ethical and make sense to help the most people. It's too hard to put it on the doctor at the bedside. Also, it has to be implemented in all the hospitals in the region, as I mentioned before. And we should look to the community and get support before the disaster occurs. You don't want to start having these discussions after something happens. And that can be very difficult if you are in an environment where it's unusual to have disasters like this and people think it couldn't happen here, it couldn't happen to me. Those can be difficult discussions, but it's important to do. Other things that we looked at is we did a survey of the literature and to determine whether there were any themes that came across in this crisis care type of situation. And we found these 4 things that were listed on this slide to be recurrent themes. One was to designate a crisis triage officer. So the same thing that you have an administrative decision, somebody who is not directly at the bedside looking at what to do. And as part of that, we wanted to make sure that we had palliative care in the triage models. So perhaps we don't have the resources to resuscitate you and it's a futile case, but we still want to make you as comfortable as possible. We want to include palliative care. That's a really critical piece. The second one is to respect the ethical principles of beneficence, stewardship, equity, and trust. And we'll go into this again in a lot more detail in the residential course and also the video prior to that. But one thing that's challenging with these ethical principles is sometimes they conflict with each other. So if you look at one ethical principle and you look at another one, they might guide you to do 2 different things. So that can be a bit of a challenge. And there's not necessarily right or wrong answers, but the idea is to respect the principles as much as possible. The third thing, and this is probably more of a concern in some countries than others, but many of the physicians were concerned about liability because there do tend to be lawsuits when bad things happen. And so they wanted regulatory relief, change in laws to provide liability protections in these kinds of unusual, scarce resource environments. And the last thing we've talked about multiple times already is prioritizing the population health over the individual outcomes. So speaking of individuals and populations, let's go back to that case study I asked you to think about. You have a patient in cardiac arrest. Do you do CPR? What's the standard of care? And I would say it really depends on the situation, whether you have the resources to do it or not. So if you have hundreds or thousands of casualties and several of them can be helped simply by opening an airway, and you stop and do CPR on somebody that's probably going to die anyway, and all those other people die because you've used your resources, I would say, no, you have breached standard of care by doing CPR on that patient and letting all those other people die. Whereas there could be cases where you have the resources to do it. I've seen, for example, a video in Israel after a terrorist bombing where they do a thoracotomy on a patient in traumatic full arrest, even though they have multiple casualties, but they actually had the resources to do that without taking away resources from the other patients. So it really depends on the situation whether it would be standard of care to do CPR or not. And of course, under normal circumstances, somebody drops in front of you in cardiac arrest and that's the only patient, it's totally standard of care to do CPR. So the point is, it's not the intervention itself, but it's looking at the entire setting. What would the prudent person do under similar circumstances? Are you abiding by your principles of maximizing population over individual outcomes if you are in a truly catastrophic situation with limited resources. Let's look a little at our facilities, because I know several of you do work in hospitals or healthcare facilities. And in some cases, of course, you've exceeded resources, but it's not always, as we saw in the Quarantelli study, a scarcity of resources. Sometimes it's a lack of an incident management system. And incident management systems are relatively new to hospitals. In the U.S., there's something called HICS, the Hospital Incident Command System. We are just actually updating that. And it's based on the same principles of incident command, but it's used within a hospital setting. But this is a relatively new thing for hospitals to work with. Here's some examples from the U.S. again, surge capacity, what surge capacity, just looking at even on a day-to-day basis. As I mentioned, my mother had to wait about 15 hours to get a bed in the hospital. There's just no capacity, even without a disaster. They saw 90% of level 1 trauma centers and hospitals with more than 300 beds were already on a daily basis at or over capacity. 500,000 ambulances were diverted in 2003. These ambulances driving around, there was an article, ambulances to nowhere. They don't have a hospital to accept them. Lack of ICU beds, the most common cause of diversion. Large urban hospitals, most likely to divert ambulances, and waiting times for emergent patients 2 times more than the guidelines. So even under daily circumstances, we are stretched to the max, and I know it's even worse in some other countries. Here's a snapshot that was done in 7 U.S. cities at a certain time on a certain day in 2008, just to get an idea of what's going on. And you can see on the slide the number of patients being treated, the ER treatment spaces, the percent of capacity being used, and the available treatment spaces. So again, even on a daily basis, facilities are over capacity. So you add a disaster on top of that, and we've got to get really creative in terms of making more surge capacity. What are some of the things you can do if you have a sudden onset no-notice event, so an earthquake or something that happens rapidly, not something you can plan for like a pandemic? You can do some things immediately. You can clear the emergency department. You can send all the admitted patients to the wards. If you're not sure of the disposition, admit them, send them to the wards. If you know they're going home, send them home and delay the care. For example, in the Loma Prieta earthquake, I walked out to the waiting room and said, we've just had a major earthquake, we're expecting a lot of casualties. If you have a minor problem, you might want to go home. And many, many people went home. In fact, it was one of the quietest nights ever in the ER because people in the waiting room went home. The communications with the paramedics were down, so they assumed we were busy and were taking patients to other hospitals, and we only got about 6 critical patients the entire night. There's another example. I got a call once at the hospital saying, we had a mass casualty event and we're going to be bringing you multiple patients, just giving you a heads up. And it was actually shift change. And you know you can never get a patient out of the ER at shift change because the nurses just won't accept the patient. But I called them and I said, look, we may be getting multiple patients. I need to clear the ER out right now. In 20 minutes, I had the entire ER cleared out because everybody was willing to go that extra mile because of this big disaster that had happened and because they knew we were getting casualties. Well, in the end, guess how many patients we got? 0. So even the idea that you're going to have a disaster can get people moving and can get things done. You can't do that over a prolonged period of time, of course, but in the short term it can be done. You can also increase the number of screening areas. Of course, you can cancel elective procedures and admissions. The administrators at the hospital don't like that because they make a lot of money, but it's something you need to do when you've got a lot of casualties coming in. Another technique we've used is you can take admitted patients from the emergency department and move them into the hospital in quote-unquote hallway beds. So in the ER, they don't say, oh, you don't have any more beds, so we can't bring patients. But on the ward, they'll say, well, the bed's not ready. well, why not move the patient on the gurney up into the hallway in the hospital? And this has actually been done even under normal operations in some places in New York to try to increase surge capacity, and it's been fairly successful. And of course, if you have any private rooms, you can make them double or even multiple occupancy. So these are some of the immediate techniques that can be used to increase surge capacity. On a more delayed type of techniques, you can look at opening closed wards. For example, after Hurricane Katrina in Baton Rouge, there was a hospital where they used some closed wards. And many hospitals average in the U.S. about 100 licensed beds more than are staffed. So the bed is there, but not the staffing and the stuff and everything that goes with it. So you can look at augmenting that if you have some time. You can have early discharge of stable inpatients. It's 2 in the morning, you're ready to go home, you're going home. We need that capacity, something you probably wouldn't do under daily operations or normal times. You can provide patient care in alternate areas, lobbies, classrooms, cafeterias. I'm sure you can think of something in your own facility. You can use temporary external shelters. We have an external field hospital, if you will, right on the campus of our regular hospital that we can erect and use in a disaster. It can be a tent, it can be a mobile trailer. And you can have alternate care sites, and it's actually required by the Joint Commission. I'm sure some of you use the Joint Commission International. It's required by the Joint Commission for hospitals to identify alternate care sites in case they need to evacuate that could be used after a disaster. So these are all techniques to augment hospital capacity. Now, how do we measure surge capacity? You know, that's another big issue. How do we measure how we're doing? How do we measure it in order to create research models? This is pretty difficult, and there's no well-accepted quantifiable measures of hospital surge capacity, although there are a number of publications and ideas out there. One of the things that's been used in the U.S. has been from our Health and Human Services, a part of their organization called HRSA, the Health Resources and Service Administration, and they have defined surge capacity as you want to be able to treat 500 cases per million population for infectious diseases, 50 cases per million for trauma, provide 250 additional healthcare personnel per million population. So you can see they have portions of the surge capacity in here. But these are very difficult to quantify. For example, the 50 cases per million trauma. If you're the 51st trauma patient, are we going to say, oh, no, we can't take care of you? No, we're going to figure out some way to do it. So it's an attempt to try to quantify, but it's very difficult. My understanding in Israel is they look at having 20% increase over daily census, but they rarely exceed 5% increase even with the terrorist bombings. So some measurements out there, but very difficult to actually quantify this concept. One thing I wanted to share with you, and Luca, I sent you an article. I'm not sure whether you can upload that, but we'll get it to you after the conference if you're not able to upload it during the conference. It's a model we developed called the COASTER model for initial incident assessment, looking at the hospital setting and what kind of tool can we create. So John Hick is the first author on that, and it's looking at a tool that the hospital incident command personnel can use to prioritize initial incident actions to address components of surge capacity. And in this tool, there are 3 major categories. Each has 4 sub-elements. I'll show that to you on the next slide. So in the COASTER model, the CO part stands for Command, Control, Communications, and Coordination. And the S part stands for the logistical requirements, staff, stuff, space, and special, specific to the event. And the TR part of the COASTER stands for tracking, triage, treatment, and transportation, so that you have basic patient care and patient movement functions. And again, we'll get that article to you, but this is the framework, and this is a model where COASTER, the C, the S, and the T, with the command, control, communication, coordination, the staff, stuff, space, and special, and the tracking, triage, treatment, and transportation. This is one model looking at what you can do in the hospital setting. And again, there are other models out there for surge capacity, but they're all pretty much similar in terms of the conceptualization of the basic components of staff, stuff, and structure. So just finishing up some of the take-home messages. The goals of surge capacity is, of course, we want to focus on the patient. We want to augment the patient treatment capacity and improve population health outcomes. This surge system, the one takeaway here, is staff, stuff, and structure, with structure really being two things, but it's easier to remember groups of three, so we put two under the structure. The physical location where you care for the patient, and then very, very importantly, the incident command system. Incident command system or an incident management system is absolutely essential to coordinate resources. Don't forget about human behavior in your disaster planning, because you can have the best science in the world, but you need to plan for what people will do rather than for what you want them to do, because people may not behave the way the science says they should behave, and we have to take that into consideration. Care definition referring to the actions of a prudent person under similar circumstances. The goal of care is shifting from optimizing individual to optimizing population outcomes when we have this scarce resource environment. And I'll share some references. These are some references on the standards of care. We actually had a meeting with the American Health Lawyers Association looking at pan-flu preparedness. And more references on standard of care. These are all open access, by the way. We had a meeting through the Society for Academic Emergency Medicine where we published, this is the issue right here, in May 2006, the proceedings in November. And because it was such an important topic, we decided to convince the journal to make it open access. So you can see all of the articles from that particular consensus conference. And we had some international input, a colleague from Taiwan, a colleague from Israel, for example. And I co-chaired that with somebody from Johns Hopkins, and we published the proceedings of that surge capacity conference. And then here are some of the references in part from that consensus conference, and then another article from JAMA on hospital disaster preparedness. These will all be available to you on the slides. And then finally, just to summarize again, the take-home message, the 3S concept of surge system, stuff, staff, and structure, stuff being supplies and equipment, staff being the personnel, but don't forget the behavioral issues and the specialized skill sets, and structure having two components, the physical location and then that all-important management infrastructure. And with that, I will thank you very much for participating and ask if there are any comments or questions from the group. And thank you, Luca. It looks like you posted the article, or Eugenio.
Yes, I'm Luca. Yes, I've already posted.
Ciao Luca, grazie mille.
Niente. Thank you very much for the presentation.
Is anybody awake? Any questions or comments? Does it make sense? Surge capacity. Any surge capacity for questions? Okay, I see a question. Is there a trigger set of triggers for standards of care? That's a good question, and it's being worked on, but there's a lot of controversy. We are having some more meetings of the Institute of Medicine at the national level looking at that, but this is one of the things that still needs to be developed. So right now I would suggest to focus on the concepts and the principles because we first have to have agreement and understanding of those, and more work can be done on getting triggers. Any other questions? Okay, I see a question. Are we still left to our personal principles and opinions? We will discuss this a lot more in the ethics session. There's going to be an opening conference like this, and then also on-site. It's really challenging, and to me it's one of the most exciting things about the EMDM is to get people together from all different cultures and values and try to understand how we can do the best for our patients with different types of viewpoints and beliefs. So there are some principles that we will help you with, but there are also going to be some personal principles and opinions that will enter into things, yes. And cultural as well. I mean, you know, for example, if you respond to a hurricane in Hawaii, you have to first sit down and have a meal with the elders before you can actually take care of patients. So again, looking at behavior and customs in addition to the science is really important. I see a question, will the surge capacity influence the triage system? Surge capacity will definitely influence the triage system. So if you, for example, don't have enough ventilators, you need to shift your triage to account for whether that patient has a futile outcome or not. There is an article called Start Then Save Triage, which I can get to you, which looks at a catastrophic earthquake scenario and looks at predicting mortality outcome and trying to change your triage depending on the surge capacity. So that's a very good point. And it can change over time depending on the event as well. So definitely yes. I see another question. Should these principles be universally standardized like all facts of medicine? Yes, I believe that they should be standardized, and part of the work we do together in the EMDM, since we have people coming from many different countries and cultures, can help with that. And that's why I believe it makes the most sense to keep some of the terminology as a universal word. For example, to use surge capacity rather than translating those two words into other languages where they can have different connotations and make things more confusing. See another question. So we never know the surge capacity of a hospital in advance because what if the disaster hits the hospital, bomb, earthquake? Well, we do know some things, we should know some things about the surge capacity of the hospital in advance. That's the idea of knowing your resources and planning. And your point about the disaster hitting the hospital is a really good one, because historically many planners have not considered what I call the hospital as a victim scenario. They think of the hospital as the place people go for help, people will come, but we definitely need to have planning and drills to prepare to evacuate hospitals, including the decision about when to evacuate the hospital, because it's not always an easy decision to do that. There's another question, like you said, it is more personal opinion or situation and available resources. Are there any current guidelines? There are guidelines, and we will talk about it quite a bit in detail in the ethics sessions. I see another part of a question, why you think it should be Why do you think it should be only one standard of care? I believe that the term standard of care is a legal definition that means what would the prudent healthcare provider do under similar circumstances with similar resources. So it's one thing that somebody would do. The treatment could be different, but the standard of care to me by definition is just one thing. It's what somebody would do under similar circumstances with similar resources. So it may change depending on the situation, depending on the resources, but it would be what would be the prudent thing to do. There's some debate on that, by the way, but that's how it makes sense to me. So the example I gave, doing CPR, it's not whether or not you do CPR, it's whether or not it's appropriate under that circumstance. Any other questions? Luca, anything else?
No, I think we finished. It was a great presentation. Thank you very much, Kristi. And the voice was perfect, and also.
Well, thank you for all the technical support.
No problem. So.